Hello everyone. Thanks for being here. My name is Jim Mielke. Unfortunately, I'm unable to be with you in person today, but I'm very pleased to have this opportunity to share a little bit about my international health and development experience with you in this video presentation. Thanks also to the organizing committee for making this all possible, and a special thanks to Naomi Glover for her invitation to me to participate in the conference today. Over the past 35 years, I've had the privilege of living and working in over 20 developing countries throughout the Asia-Pacific region. And except for about a half a dozen years in Hawaii, where I did my master's and my doctorate in public health, I've been overseas for most of this time. But one of my favorite projects is what we're going to look at today. This is the Vietnam-Australia Primary Healthcare Project for Women and Children. And I'd like to get started now. I think you'll enjoy it. The Vietnam-Australia Primary Healthcare Project for Women and Children was implemented from 1998 to 2003. Project goal: to improve the primary healthcare services delivery to women and children in 4 provinces in Vietnam. This was a bilateral partnership between the government of Vietnam and the Australian Agency for International Development, AUSAID. The project had 3 components: health services delivery for women and children, improved health behavior through community development, and project management. The project provided support to health services delivery for women and children through improved facilities and capacity for essential obstetric, gynecological, and pediatric care, strengthening of systems for skills-based training, supervision, monitoring, and referral, and to the users of the public health system through health promotion and community development activities. Key principles of the project include capacity building, cooperation and collaboration, joint planning and setting objectives, skills-based training to strengthen workplace performance, a focus on improved health service delivery for women and children's health and in line with Ministry of Health policies, linking all project strategies for best results, and of course striving for sustainability of outcomes. The project was implemented in 4 provinces: Long An, Ben Tre, Quang Ngai, and Gia Lai. Long An and Ben Tre are in the Delta area in the south. Quang Ngai and Gia Lai are in the central, coastal, and mountain region. Total project cost was 22.6 million Australian dollars over 6 years. Provincial counterparts contributed 10% of the budget. Project management units within the provincial departments of health managed the implementation, guided and supported by an Australian advisory team comprised of a team leader, training advisor, maternal and child health advisor, and the health promotion and community development advisor. 3 of the members were Australian, and I was the only American on the team as the health promotion and community development advisor. My teammates like to refer to me as the ethnic minority. Overall project achievements: working in 4 provinces, 29 districts, 152 communes, reaching 2.5 million women and children under 5, training nearly 3,000 completed formal training courses, these were health workers, and another 1,540 completed informal training programs. 130 health facilities were newly built or refurbished. This included commune health stations and district hospital MCH centers. Sanitary facilities were upgraded, including safe water. Medical equipment was supplied for all project sites, 19 district hospitals, in obstetrics and gynecology, pediatric and laboratory equipment, as well as in 152 commune health stations. Transport: 4 project cars, 24 ambulances, 57 motorbikes, 456 bicycles, and 18 motorboats. 28 master trainers were trained, who then carried on to train 236 provincial and district trainers. Training equipment was supplied. Provincial, district, and commune level staff were trained in emergency obstetric care, integrated management of childhood illnesses, and supervision. Laboratory skills training was provided at provincial and district levels. Provincial, district, and commune staff and community organizations were trained in community-based health promotion. Community-based primary health promotion activities were supported through mass organizations and village groups. These were small grants that were awarded to communities that participated in their assessment activities to identify priority needs. Information, education, and communication materials were produced and distributed. General management strengthening and support was provided to provinces in the areas of training, office equipment, and study tours. 29 postgraduate master's students studied with project scholarships, including 9 who studied overseas. Finally, an ex-post evaluation conducted in 2007 found sustained impact from improving trends in provincial and individual health center MCH data. While the positive impact indicators and outcomes cannot be totally attributed to the project, although many key informant interviews referred specifically to the role of the project in improved processes, outcomes, and results. Rather, the project contributed to overall health improvements in Vietnam achieved through government and international partner activities. Okay, I'm going to show you a set of photos that will hopefully bring more of this to life for you. Okay, here we are in Vietnam. Just to remind us here of the lay of the land, Vietnam is part of Indochina. The project areas were in the south, 2 provinces in the south in the Mekong Delta, and 2 provinces in the central coastal and mountain regions. It's a closer picture of the country. We worked in the Quang Ngai province and Zalai province, and down here in the Delta in Ben Che and Long An. Just some photos to give us a little feel for what it's like in the Delta region. Very beautiful, lush, watery areas. Waterways are a principal means of transport. This is one reason why the project provided project boats for emergency delivery of patients from outlying villages taking waterways. It might be the quickest and easiest way to get there. Lots of poverty still, very poor basic communities. Still very basic level existence out here in the back country, the communities. Although I understand Vietnam in recent years has become one of the fastest growing economies in Southeast Asia. Very switched on place. They're really off to the races. But there's still a lot of very basic needs in these back areas. Some basic transport here, lots of wonderful fruits and vegetables. It's also a major rice producing area in the south. Even in the central area in the mountains, if you can imagine, skinny little Vietnam has the 2nd largest coffee production in the world, even after Brazil. Okay, moving into the project now. You can see some of these materials that the project produced. Teaching materials about various aspects of maternal and child health, information, education, and communication materials. Provision of upgrading of the commune health stations. Again, a major focus of the project was to improve access for emergency obstetric care, addressing the higher maternal mortality rates, particularly in the outlying areas. The project provided training on communication skills for health workers, and also training on how to use these new teaching materials. Many times health workers perhaps may be trained as medical doctors or technical people and really need help to learn how to use very simple language so they can communicate more easily with their communities. The project provided very basic skills for something as simple as mixing oral rehydration solution. It can be life-saving for a baby that's got diarrhea. Sadly, much of the water in the south has been polluted and probably will be for some time as a result of the American War, as it's referred to in Vietnam, the American-Vietnam conflict. The air bases of the American military and the Agent Orange, unfortunately, has left a lot of arsenic, Agent Orange, this kind of thing. So the groundwater is not able to be used for drinking. And many of the rain catchment tanks, people would traditionally catch rainwater off their roofs, a lot of times weren't big enough to last through the dry season. So the project provided some larger rain catchment containers. This is a typical scene in the Delta. This is a typical toilet. Driving through the Delta, you see people sitting here in the morning reading a newspaper, while over here, their family's over here brushing their teeth, washing their dishes or their clothes, and they wonder why they're all sick. So the project also, as part of these small community grants, communities themselves would identify that these are issues that need to be addressed, and they'd have grant money provided then, for example, to build pit toilets. Seed money was also provided for women's credit savings groups. And then again, they would borrow money to start up their credit savings group, come up with a project, for instance, safer water or better nutrition for their children, and then they'd be able to eventually pay back their loan. In the mountains, however, we were able to drill wells and have fresh water in the mountain villages. So you see a number of these water projects were, again, proposed by these communities after they did their needs assessments and were able to come up with more fresh water. And here's some happy recipients of the fresh water in their communities, some happy and healthy looking mothers and babies. But none of this would have happened without these people. Worked very closely with the master trainer, Dr. Lady Tree, and these are all provincial and district health trainers from the 4 provinces. And these became the trainers who then would train particularly in the community development and health promotion component of the project. There are another set of trainers who did training in clinical skills in mother and child health, as well as in project management. Training was provided to both these provincial and district trainers, and once they finished their training program, they would go in teams, 1 provincial trainer and 1 district trainer, to provide health promotion and community development training in the districts. Here are some of the trainees practicing their health promotion skills using health promotion materials. Interviews were practiced as well as part of the Participatory Rapid Appraisal Program. PRA was one of the training areas, one of the skill areas we trained in. Here you can see some of the community people have put together, begun mapping their resources and their potential as part of the PRA process in the communities. This is Participatory Rapid Appraisal. Very effective in terms of engaging community people in identifying their priority needs and also understanding what still is needed to help for them to reach their goal. Identifying the local resources, mapping the community to see exactly what exists out there and what they still need. Again, a very dynamic process. And again, this came up with villages and communities able to propose then for their small grants to get something like fresh water in their community. This is a group of health volunteers who are also trained. They're very key personnel in the community. They don't get paid, but they get recognition in kind in many places. They are key personnel to support the outlying health stations, oftentimes staffed with just 2 or more health workers who have to look after a very large community, very large populations. And these people would be, for instance, in reminding pregnant women to come in for their antenatal checks, making sure they come in for their children's immunizations, this sort of thing. A very delightful process. This is my assistant, Tweed. He was, again, all of us on the Australian team, each of us had a national officer. We couldn't have done this project without these people. They're not only providing translation services for us, even though I could speak pretty good Vietnamese at the time, but they're also very, very important, helping us to learn how to work in Vietnam within the context also of the government health system. Tweed is one of these wonderful people. He's a great friend of mine. He's a medical doctor, trained lawyer, and a specialist in community development. You see a lot of this in Vietnam. Very, very switched on people, very committed to helping their people. And here I am getting inducted into the Communist Party. Not really. This is just opening one of our workshops. This would be the provincial health education person. This is in the province of Quang Ngai, and the district health director. It was interesting in Vietnam, you oftentimes would see women in fairly high positions in the health department. We also had a very strong gender component in our project. Because we controlled the money in the project, we could also stipulate that at least half of the trainees for our training programs had to be women, and they had to be very clearly, specifically appropriate for that particular training. Whenever we came into a community to work, we always had to arrange to meet with the local authorities, the People's Committee, they were called, and just to let them know what these foreigners were doing in their committee, what's going on. They just needed to know what was happening, and they were always very receptive and very supportive of the work we're doing in the communities. But it's part of the protocol when you work out in the communities in Vietnam, just making sure the local people in charge are aware of what's going on. Some of our trainers in Quang Ngai province, great guys. And this would be a typical situation after, say, a week workshop of training. This is a district director who's just offering a gift of thanks. And of course, we're having a wonderful meal, great food. Usually you have to get most of your work done in the morning, though, in Vietnam, because there's quite a bit of alcohol at lunchtime, and the afternoon is pretty well shot. So mornings are when you get your work done. But anyway, part of the whole process is building relationships and working together. It's great. We also worked in the ethnic minority communities. A lot of them needed water projects. Here's a well that's no longer good. Again, we're here to help them build a new well. These are people who are very, very poor and in very remote areas. But at the same time, we're still able to train women in these communities. For example, here's an ethnic minority woman who's been trained to take her own notes and do her own research in the community to identify the community's situation, their key problems and needs, and the priority issues to address. This is part of the process of participatory rapid appraisal, and it was really neat to be able to show some of the health authorities, oftentimes male doctors, who would be kind of suspicious, thinking, oh, these women, they're low educated, they're really not going to be able to do this. But in fact, many women, most women in these communities, they're the ones who know what the key health issues are. They take care of the health of their families. They know each other. They share their problems, and they're really dynamite, great to work with. Just again, some of the weird scenes. Did a lot of work out in the community areas, out in the rural areas. Some kids out here fishing. See a little lay of the land. Here we're on our way to another ethnic minority village that has just completed a water project. This is our cameraman getting a hoist across the stream. This is one of the water catchment facility that's been built from project money. And here's some of the people involved in the project, including the village headman. The young woman there is the health worker in that community from the government, and some other project staff. And if you ever get lonely when you're working out in these places, just find some kids, they'll love you. And particularly, they go nuts when they see a foreigner. It's a lot of fun. This would be a typical health education message that's, again, geared towards lower literacy populations. Just a scene of Quang Ngai town from my hotel window, get a little more feel for what it's like in the central region of Vietnam. Very mountainous, rugged countryside. The roads are pretty rough, pretty tough getting around. And this is a very common scene throughout Vietnam. These are memorials from the war with the Americans. The Americans lost about 55,000 American soldiers. The Vietnamese, about over 3 million died in the war. And these memorials are everywhere. This is a French-built hospital, again quite old and would be refurbished as part of the project. Some of the workers there. In the central region near Da Nang, this is China Beach, famous for surfing in certain times of the year. We'd often take a break here after working in the central region, take a weekend here after a week out in the village. It was really nice to hang out at the beach. This is a very pleasant scene from the town of Hue, cultural center, university town, very scenic. This is also in the central coastal region of Vietnam. And as usual, we'd have very lovely hotel clerks and registration clerks. You can see these women are dressed in their traditional ao dai the traditional dress for Vietnamese women, and this is just at one of our hotels. Tuyet is pictured here with his parents. And this is a very typical scene of Vietnamese schoolgirls in their traditional áo dài, pure white. I don't know how they keep them clean, riding those dusty bikes around everywhere, but they do. Some more scenes from around Hue in central Vietnam. This is a night scene on Hoan Kiem Lake in Hanoi, in the north of the country. Just a little bit of scene from Ha Long Bay, very famous for its karst formations, these very steep, dramatic limestone islands. In the far north on the China border, in Sapa, there's mostly mountainous terrain, very beautiful, great for trekking. And then back down in Saigon, Ho Chi Minh City, here's a typical traffic snarl during a downpour. See a lot of this in the big cities. And this is my landlord, wonderful guy, Mr. Ngap, who had been in the Southern Army during the war and subsequently survived 14 years of re-education camp on the border. Afterwards, he came back to his family home here in Saigon and converted this big old French villa into a set of apartments, and a number of us were renting there with him. It was really fun staying there because he got to hang out with his family and with some of the other people that lived there. It was always a lot of fun. I always have preferred living kind of locally. Many consultants, foreign workers, tend to stay in these gated foreigner estates. They're very comfortable, very clean, very safe, but kind of sterile. And of course they're more expensive. So I really loved hanging out with all the local friends here at Mr. Ngap's house, and subsequently made friends as we went along. We're just having a party here, which was pretty common. And Mr. Ngap, a typical Vietnamese, he rented out every spare space in his house. So his kids actually had to sleep in the cupboards in the kitchen. Another nice thing about where we lived just across a field from this beautiful Olympic-sized pool right in Saigon. I could go swimming every day when I was in town. Again, with lovely friends from Saigon. Here we're at the beach. This is typically how you'd get around the Mekong Delta in the old days, but more and more you see this kind of thing. This is a bridge that was built as a gift from the Australian government. See more and more development here happening. Vietnam is changing very quickly. This is opening day for that particular bridge. Finally, when I finished the project, I went to this island called Phu Quoc Island, which is in the south of Vietnam near the Cambodian coastline, and stayed here for 2 years. It was absolutely wonderful. I rented a beach bungalow. This is a beach house I rented for the first year on a pearl farm. My buddies ran a pearl farm down there. And this is our housekeeper, Guy. She now runs her own restaurant there on this beautiful, unspoiled island. Some more friends there. Marie there on the left is a Viet Kieu from France. She had come back to Vietnam. She's a businesswoman and began developing a bungalow outfit to rent to travelers. Beginning to develop this island. It had been very undeveloped and again changing very quickly. Just some more of the villagers there. This is the view down the beach from my place. Rented this bungalow for $100 a month from a local family. It was just delightful. There was a nearby restaurant that took care of me throughout the nice season. In the rainy season, they just pulled up the stakes and went back to town, and we all left for the storm season. Then we'd come back when the weather got nice again. Phu Quoc Island, again, another beautiful paradise in Southeast Asia and Vietnam. And we'll leave it there. I hope you enjoyed this presentation. Thanks again very much for joining.